Hello, everyone, and welcome to week 3. Today, we will be discussing ICD-10 coding. My name is Cynthia Bennett, and I will be your facilitator for this session. So here's an overview of ICD-10 CM. It's a classification system of morbidity, also mortality. ICD-10 stands for Internal Classification of Diseases. WHO's is actually the organization that oversees ICD-10, and ICD-10 is used globally. WHO actually stands for the World Health Organization. ICD-10 means the 10th revision, and the CM stands for clinical modification. Continuity of data. And then here is a sample of the index in your ICD-10 manual. So you'll notice the diagnosis, and then you'll also see the actual code next to it. And in some cases, it'll give you some additional information or instructions that you need to follow to assign the correct code. So ICD-10 is divided into chapters. So your chapter 1 is going to be for your infectious and parasitic diseases. Chapter 2 is going to be your neoplasms. Chapter 3 is going to be your diseases of the blood. Chapter 4 is going to be the endocrine system. Chapter 5 is going to be for your mental health. Chapter 6 is for the nervous system. Chapter 7 will be diseases of the eye. Chapter 9 is going to be your circulatory system. Chapter 10 is your respiratory system. Chapter 11 is your digestive system. 12 is going to be your skin and sebaceous tissue. 13 is going to be the musculoskeletal system. 15 is going to be pregnancy, childbirth. 16 is going to be your perinatal period. 17 is going to be for your congenital malformations. 18 is going to be for signs and symptoms. 19 is going to be for any type of injuries and poisoning. 20 is going to be for any external causes. Now, you will notice that each of these sections that I just identified, they are identified with a range of codes as well. So for example, chapter 1 is going to be A00 through B99. If it is a neoplasm, it's going to begin with C00, and the last section for that is D49. So you'll start to notice that there is a pattern when it comes to the different diseases and the different diagnoses and their categories. So 20 is for your external causes, 21 is for factors influencing your health, and then 22 is for special purposes. So in the tabular list in your ICD-10 coding manual, where you see the red dot where it says R10 abdominal and pelvic pain, that red dot lets us know that we need to add some additional digits to that code. So that is not a valid code unless we add some additional digits to it. So in this case, we would have to add the 0 so that we can get the code for acute abdominal severe pain. And that's R10.0. But this is basically how your ICD-10 tabular list will look. Now you will have official instructional notations, and you will see these notations throughout the book. So in this notation here is letting us know that it includes diseases generally recognized as communicable or transmittable. So a lot of times it's going to give us some additional information about that code. So sometimes you will see a note that will say excludes one. And what that means is that it is not included. So you'll see excludes one. That means that won't be in that actual section of the ICD-10. Also, you'll see excludes two, and it says not included here. So you will see situation where it says excludes two, and then here As an example, carrier or suspected carrier of infectious disease. And then it's letting us know which actual code that we should be using. So you'll also see notations sometimes, such as code first. So in this example, the patient has streptococcal sepsis, but it's letting us know that we need to code one of these diagnoses first before we code that code. So whenever you see code first, that's what they're actually trying to tell you, that you need to code something else before you actually assign that code. You'll also see code also. So code also equals more than one code is required. So what it's telling you is that if you're going to use ICD-10 code D61.82, that you need to also code the underlying disorder, such as malignant neoplasm of the breast. So they're letting you know that, or if it's tuberculosis. So before we can actually assign that code completely, we need to also code that as well. There's also the seventh character and placeholder. So you'll notice that the X is the placeholder. So in the example that I have below, you'll see it says M22.8X1. So the placeholder in this example is going to be the X. And so it's letting us know that at the end, we need to add that seventh digit. So in this case, it could be a 1. If it's the right knee, it could be a 2 if it is the left knee, and it could be a 9 if it is not documented which knee it actually is. You'll also see first listed diagnosis. So ICD-10 guidelines state that the principal diagnosis in an inpatient means is used in an inpatient setting. So if you see principal diagnosis, think inpatient setting. First listed diagnosis, that is going to be for your outpatient setting. So there's a difference. So your principal diagnosis is for your inpatient. First listed diagnosis is for your outpatient. Primary reason for the encounter. So here's an example. Patient with inguinal hernia presents with shortness of breath. So the SOB, which is shortness of breath, is the first listed. And it's first listed because in this case, this is for an outpatient service in this example. So that's why it would be the first listed instead of a principal diagnosis. Unconfirmed diagnosis. So in an outpatient setting, it may take several encounters to confirm a diagnosis. So some of your codes that you may encounter may be an unconfirmed diagnosis. So if that is the case, we're going to actually just code the signs and symptoms that are reported. So one example that could happen is a patient comes in and they may have a sore throat. But at that time, we don't know the reason for that sore throat. The doctor runs a test, determines it's strep throat, or sends it to the lab. And then the lab, then determines that it's strep throat. But we don't have that at the time when the patient came in on that first visit. Maybe they come back in for another visit, then we can use the strep throat. So we only assign diagnoses for confirmed diagnosis. If we don't have a confirmed diagnosis, we'll use the signs and symptoms for which that patient came in for. So here's another example. Patient presents with a complaint of frequent heartburn. The physician prescribes Prilosec for suspected GERD, patient returning in 10 days. The key here is that it is suspected GERD. So whenever the doctor says suspected, rule out, possible, any kind of names like that, that is not a confirmed diagnosis. So what we're going to actually code is the frequent heartburn because we don't know for sure whether that patient has GERD. We just know that the doctor suspects it. So we can't code that. So we're just going to code what is confirmed, and that is that the patient does have frequent heartburn. So we can go ahead and assign a code for that. Outpatient surgery. So we're going to code the reason for the surgery first. If the surgery is not performed, followed by the code to report the reason for the procedure and the reason why it was not carried out, such as the Z53.09 procedure not carried out due to contradiction. So there will be times where that actually may happen, and we'll have to assign those codes. We also have Z codes. Now, in your Z codes, those are to report circumstances and other diseases or injuries. Z codes are informative and they may be listed first or additionally. So it depends on the code, and when you look it up, they will let you know whether you can use it as a first code. So depending on the circumstances, Z23 reports encounters for inoculations and for vaccination. So that those codes will begin with the Z23. Procedure code identifies the administration. So we'll have sometimes where the patient will come in for an observation stay. So for those patients, we'll choose a code from category Z03 and Z04. So these are for our patients who are just coming in for observation. So the patient is admitted to observation status, and this normally will happen through the emergency room. The patient will come in, and then the doctors will say, I want to observe the patient for 24 to 48 hours. So then their status is changed from ER to observation. So we'll have to look at the patient status for that. We'll report the Z code as first listed for the diagnosis stated as suspected or rule out condition. If a diagnosis is made, we'll report the diagnosis as first listed. For an uncertain diagnosis, if it is inpatient, report the uncertain diagnosis as if it exists. So that is the one key difference between inpatient and outpatient. In this case, for inpatient, we're going to report that uncertain diagnosis as if it already exists. So probable, suspected, questionable, rule out, working diagnosis, etc. These will all fall under that uncertain diagnosis. So if it is an outpatient service, we will report the signs and symptoms, abnormal test results, or other reasons for the encounter. So as you can see, there are some slight differences in between inpatient and outpatient. So for chronic diseases, chronic diseases are treated on an ongoing basis. So patient has diabetes, they have hypertension, things like that. Those will be considered what we call chronic diseases. So there's ongoing treatment for those diseases. So we're going to report the condition as many times as the patient receives care or treatment for that condition. So for example, with the diabetes, if the patient comes in once a month and they have diabetes, then that will be the diagnosis, and that is considered a chronic condition. Do not report conditions that were previously treated and no longer exist. So we want to make sure that we're only coding things that are for that visit. So maybe the patient previously had pneumonia in the past, but maybe they don't have it now. We don't want to report that. So make sure that we're not reporting conditions that no longer exist. We want to report a history Code using a Z80 through Z87 as secondary diagnosis if a condition impacts the current condition or affects treatment. So those are going to come from your Z codes. And if you forget any of this, once you go into your ICD-10 coding manual, this information is available. So pre-operative evaluation. So when a patient is going to get a surgery, a lot of time they have to get what's called a pre-op exam. So in those cases, we're going to code the first listed code for any type of pre-op exam. And those are going to be coded with the Z01.81. And that is encounter for pre-procedural exam. Z01.810 is a pre-op for a cardiovascular exam. Z01.811 is a pre-op for a respiratory exam. Z01.812 is for a pre-op lab. So you can tell that there are some differences. So again, paying attention to the details will ensure that you assign the correct code. So Z01.818 is for a pre-op exam, not otherwise specified exam before chemo. So this will be for our chemo patients. We will use that code. So additional code, the reason for the surgery. So we also have pre-op and post-op diagnoses. We want to report the most definitive diagnosis. Usually the post-op diagnosis is going to be the most definitive diagnosis because the patient is already there. They went through the procedure and the process. So this will be the post-op diagnosis. And this can differ from the original diagnosis, which will be the pre-op diagnosis. So we have to pay attention to those details. And this will conclude our lecture for this week.